I'm going to be showing a series of releases for the neck. There's work for anterior, lateral, posterior regions of the neck, and one of the things that I want to encourage all of you to explore is doing work around the neck that's much more specific, and I want to discuss as I go along some of the issues that have come up around the neck, the vertebral artery test and so on. And I want to introduce this work in a way that's respectful of all of those possible difficulties that might arise, but also keep it in the context of the fact that from the perspective of soft tissue therapy, there's very little documentation of any injuries that have been done to people. So that perhaps there's been a tendency to be overly cautious when working around the neck, and that's regrettable because many times people aren't getting work on their cervical spine of the kind that they need to help them resolve difficulties in their neck that come from particularly cervical whiplash is a very common one, but occupational stress as well. The time we spend sitting at keyboard computing seems to be in many lives at the moment, and so having some way to work directly, effectively with the neck in detail, I think is very essential in any massage, soft tissue therapy, manual therapy practice. So the first work that I'll do here is very broad, and it's this whole region from the mastoid process of the temporal bone along the mastoid bone, or mastoid process I should say, to the occiput, and it's done with a broad soft fist, and by soft fist I mean something like this rather than a more kind of martial idea, and the contact is made right up against the mastoid process. So I'm taking my knuckle onto the process, really the first MP joint, but also distal from that along the shaft of the bone, so it's not really just the straight knuckle. And then I land and I sink, take up a tension, not a lot of tissue there of course, but nevertheless I want to engage it and put a line of tension in it, and then I'm just going to bring that from anterior to posterior. So I'm following the contour of the bone here. And this is one of those wonderful, broad, general releases that this work does so well. It's affecting not just the SCM, which is the most obvious muscular attachment at the mastoid process, of course, but affecting many layers of muscle and fascia that join the head and the neck. So taking that as far around as I can get my fist. I'll show that again, and it'll have a variation on it, and it will look identical. I just want to describe a slight shift of where the contact moves to. So I've worked on the mastoid process, and in my practice, in my initial work around the neck, I'd repeat that 2 to 3 times, that line I just took. Next, I would work with the same line, but this time I'm submastoid and suboccipital, so it's the same soft fist. A little bit more tissue to land and sink into, and then I'm landing and sinking, doing just that, and bringing the tissue, my fist and the tissue from anterior to posterior. And once again, this has a broad effect.
Okay, here I want to use the skull to illustrate a few important things about this area and just to confirm and reinforce the contact being made specifically up against the mastoid process, and that contact carrying along the temporal bone and then passing on to the occiput. And this is very important to keep the contact right up against the periosteum all the way. The second contact is made just slightly submastoid, so that takes us more into the soft tissue right along underneath the temporal bone and underneath the occiput. There's still some bony contact there, but this time the bony contact's not so much the direct type that it was in the first round. Next, I want to show some work that affects a number of structures, and it needs to be considered that all of those structures share the same layer of fascia. And so the muscular structures are the scalenes, or the scaleni, the levator, scapula, and splenius capitis, and the contact is made through 2 or 3 fingers right over the top of the SCM, a couple of centimeters below the mastoid process. And the first contact, like everything that we do just about in this style of work, the first contact is to engage the tissue by sinking this time towards the midline, so towards the spine slightly. Then I can feel, as I apply that pressure, I can start to feel that I've got some contact up against the bone, but it's not sharp pressure. Then I'm going to put a slight inferior drag through the tissue. So that's my first line of tension, is inferior. And then I have another line of tension that I'm going to develop, which is then to take this tissue posterior. So there I'm putting 2 lines of force through the tissue and working quite slowly, as you can see. And thinking about an effect not only on the muscles but also the fascia associated with them. And letting my fingers rest up against the periosteum, and now I can feel the anterior part of the transverse process or processes. And this is what I'm encouraging you to explore, is not being overly hesitant around bringing some quite specific contact through this anterior lateral work here. Now my fingers are passing behind, posterior of the transverse processes, and I'm able then to turn my fingers on their side slightly, and now I'm lifting anteriorly slightly so I can continue to trap the tissue there against the posterior part of the transverse process. So I'll show that not on my model's body this time. Contact is towards the midline. There's the contact sinking, taking up a tension in an inferior direction, then adding a line of tension in a posterior direction. So I've got both of those vectors in place at the same time, bringing that around towards the table. As I get to the table, I'm turning my fingers up under the spine. And you can see that there's quite a bit of displacement possible there. So it's just a fairly low grade, kind of very gentle mobilization. I'm just very lightly nudging up against the vertebra, but mostly thinking about the soft tissue the whole time. But you can see that there is a little bit of a response right through the cervical column there. I'd repeat that in a number of sites, Same protocol, starting over the SCM, taking up attention, then adding the next vector, which is anterior-posterior. And I'll just leave that and just move to the next part. And so once again I'd end up with my fingers underneath, behind, posterior of the transverse processes, lifting now in this direction. So I'm wrapping around the neck, a little bit like wringing Marin's neck here. Here I'm using the skeleton to show the pathway that I make as I'm working along this lateral aspect of the neck, and I want to draw attention to what my fingers do as they go around into the posterior aspect of the cervical spine. So my fingers are then really wrapping in and pushing back up against the lamina, and of course there's a lot of soft tissue between the surface and the bones there, so it doesn't feel, of course, directly onto the bones the way it looks here, but that's the emphasis is to keep the pressure against the bones and the contact. And as I come round right towards the midline, I'm turning my fingers over on their side and really lifting back up in an anterior direction, so I'm exaggerating that lift in the spine there, so you can see that there's quite a bit of intention to really keep the tissue pressed up or trapped up against the vertebra as I'm still moving across to the opposite side. And this can be repeated, of course, in a number of sites through that area. Third thing that I'll do is to affect the medial and anterior scalenii with my finger just superior of the clavicle and depressing inferiorly and starting to move then medially. So that's going to land me on the first rib, and as I land on the first rib, or get a sense of the rib, not possible on every person to get this very clear sense of the periosteum of the rib there, but nevertheless that's what I'm approximating, even if I can't find it. I've picked the head up here and side bent it into my work. So I'm initially put side bent and flexed, so that means I've put these muscles on slack to begin with so that I can more accurately detail the work right along the first rib there. And for many times where that first rib has been held in an elevated position, which is what it tends to get stuck with because the scalenes pull it up, particularly if people are big accessory breathers. They're using the accessory breathing muscles a lot. Those scalenii will be active and they're pulling on the first rib, elevating it. So the rib tends to get fixated in that elevated position, and many times as you're working here have this really very nice sense of the rib resting back down towards the pelvis. Yeah, so you'll feel the soft tissue give way, there's a nice palpable softening, easing, melting, and then the next thing a feeling that the rib is suddenly able to rest more readily down back towards the rest of the ribs. So the finger following that line, and when I come to the clavicular portion of the SCM, I just tuck my finger slightly under that. Now there's not a big cavity there, but I still, if I direct my contact right through underneath the clavicular portion there, I'm really pointing right towards the anterior scalene attachment at the rib. And once I've got some good response built there, and by that I'm saying that I've got a palpable feeling of soft tissue release, the rib is feeling more pliant, more responsive, then I might engage my client in a little bit more active movement. So that could be as simple as just lifting the chin up and then rolling away to the other side. Yep. Yep. So once again, chin up, that's an extensor action. And as the extensors activate, then the flexors will be lengthening, and quite often you'll see that again right through the front of the body, not just locally where your fingers are working, but the sense of the line of continuity right across the front of the body as the whole flexor chain relaxes and lengthens. Okay. That's good. I mentioned earlier that I wanted to basically move towards some increased specificity with work around the neck, and one of the areas that commonly, and this is just based on several years of observation in the classes that I teach, one of the areas commonly that seems to be pretty much off limits, and unfortunately so, is specifically the anterior structures of the neck. So I'm going to show a number of ways to work there, and I'm certainly not proposing that suddenly we throw all care aside and just proceed into the neck in a kind of cavalier manner. But if we work thoughtfully and we work with some intelligent appreciation of the structures that are around there, then we're going to be working safely. And the first thing that we do to be safe, and is state the obvious, is that we just work one side at a time. So it's unilateral work. As tempting as it might be to get on both sides of the anterior neck at the same time, it's just not something that you'd want to do. And the first layer is quite to the surface, and this is the infrahyoids. So those various muscles that are coming off the hyoid bone and slinging down towards the clavicle, or the different places that they go. And I'm just going to be working between the SCM and the trachea. So there's the SCM, there's the cartilage at the midline, and it's not terribly deep, it's just in the surface, a little bit than platysma, so I'm affecting the platysma as I go. And that's very superficial, the platysma, so I'm more interested in the infrahyoids themselves, but certainly the platysma is coming along for the ride here. And you can see that I'm not going back posteriorly very far, but I'm wanting to land and sink and hook a layer of tissue here. And this is terribly important work for working towards the resolution of whiplash. So the anterior structures as well as the posterior structures get damaged during the hyperextension and hyperflexion phases of whiplash. So you can imagine that as the head whips back, then these structures in the front all the way through to the deepest layer, longus colli and longus capitis, are traumatized. You can see that's just a long line of contact until I come up under the hyoid bone, which is where I've come to just here. So there's a fair amount of territory to work with there. Like everything we do, we'll discover that the tension's not uniform. There'll be some areas that are definitely more bound than others. The more you do it, the more you'll get comfortable with working with the areas where you feel the specific restriction. So I'll just go through that again. I'm landing just medial of the sternal portion of the SCM and sinking towards the table. Not going very deep, but really got a clear sense that I'm engaged with infrahyoid. And this is work not only for the neck itself, but also important in terms of balancing the jaw. And so the way that the jaw functions is determined not just by the local muscles at the jaw, but also the muscles that come from the mandible to the hyoid bone, And then because hyoid bone is position is determined by suprahyoid and infrahyoid muscles, then the actual motion of the mandible during opening and closing, the tracking of that bone, is determined by these muscles as well. So these need to be included in your thinking when you're considering restrictions, problems at the area of the temporomandibular joint. Now suprahyoids, I'll just have Maren, a little bit of capital extension or backward bending toward at the top of her neck. I'll just take my finger in on the midline here. And I can feel the hyoid bone. I can actually palpate the hyoid bone and test for its translation. How well does it translate? And what I feel here is that it moves fairly easily to the left but not so readily to the right, so there's some kind of pull across to the left. And it's a bit harder to overcome that as I try to move that bone to the right. And that's convenient because I was going to work on the left side anyway, but that would be one way that you would start to determine where the tension might be. And I'm just going to take my finger up really effectively into the floor of the mouth and just systematically work along in the floor of the mouth towards the angle of the mandible. So taking our time rather than going at it too rapidly. And you'll find that as you work with that systematically over a couple of minutes, that you'll get very palpable softening. Here I'm just getting my finger against the mandible and just working slightly towards the hyoid bone this time. So I'm not so much working from medial to lateral, but I'm just working a little bit in to the floor of the mouth and then taking that down towards the hyoid bone. So affecting digastric in particular. Some of you will work with children who have difficulty with forming speech, that their speech is compromised by a high degree of tension around their jaw. And this work is beautiful work to help lower the tone, the stiffness through this area, so functions even more basic than speech, but even basic functions such as swallowing can be greatly enhanced by working with these suprahyoid muscles and the infrahyoid muscles, but also with the formation of speech. You'll find that tongue placement and control of the tongue and the coordination of the tongue will improve as a result of this work in this area. I'll go back and palpate the hyoid, and that just gives confirmation that there's been some good release there, so easier translation now to the right. And in a session, even where I'd be working with a very specific asymmetry like there was here, I would still do a little bit of work under here because I still want the sensory stimulation. Even though here I'm working with some structural limitation, I still want the person to get a sense of, this is where this part of my jaw is, this is where my tongue is connected to. And so this is important. So even though I might not spend as much time over here and I might not have the same detail of structural work, nevertheless I've still got this need to give the person a good sense of spatially, this is my jaw, this is where it is, this is this space that is my throat. Okay, good. The deeper structure in the cervical spine, in the anterior section, is longus colli, and also its close relative longus capitis. And so I want to show two ways to work with that. One is right through the anterior
section of the neck, and the other one is to come from behind or posterior of the sternocleidomastoid. So here's the first one. It looks just like the infrahyoids, it's just that it is going to go a little more deeply so that I can start to sense the fascia and the muscles that lie along the front of the neck. So that's so that you get a good view of that from a close-up camera, and then I'll just be moving my fingers back there a little so I can do the release effectively. So I'm just supporting my working finger there with the other fingers. My fingers are fairly big, and so there's really just room for one of my fingers there, but sometimes if your fingers are small, certainly you might find two fingers will work. So there I'm between the SCM and the trachea again. It's just that this time I'm a little bit deeper than before, and I can feel the anterior surface of the cervical spine here. And I'm not trying to push very firmly up against it, I'm just working my way at that layer where I can get a sense, oh, there it is, but also being cautious not to push too firmly through into that. So that's longus coli and longus capitis to some extent, and taking that up again to the hyoid bone. So that's the first way to do it. And then there's another way to do it. And this one might not get the same fibers, but it certainly feels less intrusive to the client, and so that can be important too. So it might not have the same specificity, but it still takes the contact right into that anterior portion of the cervical spine. So there's the SCM, that's the clavicular portion, and I'm taking my fingers and pushing it anterior, sort of out of the way basically. And now I can let my fingers then turn back towards the table, and there I am up against the anterior surface of the spine. And where somebody's had chronic pain and stiffness associated, well, for any reason, but particularly for whiplash, auto accident, or other sources of whiplash, of course, I'll work with this very methodically. I'll work through here 3 or 4 or 5 times, just progressively desensitizing this area and then mobilizing it. And the effect of this can be pretty astounding. There's just a lot of congestion there, a lot of fascial stiffness, a lot of changes in the autonomic nervous system. We've got a very interesting convergence of structures right around C1, just a little bit above that, where we've got the only site in the body, as far as I know, where the somatic, sympathetic and parasympathetic nervous systems all have some fibers. And so it's tremendously important for the well-being of this region that this whole fascial connection along the front of the spine up into the basilar portion of the occiput be open, not restricted, fluids moving through there well. And so as the fluid moves through there well, the interstitial fluid, the lymph, then we're getting good removal of waste material, and we're also increasing the arrival of nutrient material, and all of that contributes to a significant change in the well-being of our clients. So there it is again. I've just got my finger just along in front of the spine there, tucked underneath the sterno. Going?
Okay, so I've got my model up off the table here for a minute. I want to talk about a couple of issues with the thoracic spine in relationship to the cervical spine. And one of the things I want to put into your awareness is that the cervical curve wouldn't want to start right at C7T1, that the cervical curve would start, that the reversal of the kyphotic curve in the thoracic would start in the area of T4. So we don't want to see the thoracic kyphosis carry up to T1 and then suddenly try to build a nice cervical lordosis at that point. So we're looking at some transition zone where the thoracic curve, the kyphotic curve starts to then transfer across into the lordotic curve, and many times you don't see that. You'll see that these vertebrae here, these upper thoracic vertebrae, are still in quite a distinct flexion position. And this then puts a lot of demand on the neck to kind of form its own lordosis kind of within itself. And where the curve should be forming is lower than that. And so some of the work I'm going to be doing next is just to create a slight, well, I shouldn't qualify that, it's not a slight, but I'm going to be working with the deeper muscles right along next to the spine here. Merrin's going to be lying supine. I'm going to be working with my fingers on either side of the spine. Where there's that continuous flexion position coming up towards C7T1, then I want to start to affect the cervical strain by releasing that. So my fingers will be there working, helping these vertebrae here go forward or move into extension. Then working with the posterior neck should be preceded by doing some work with the thoracic spine a bit lower down. So I'm going to reach, just lift one shoulder so I can shoot my hand down to the area of T4, and then Merrin's helped me by lifting the other shoulder. So there, my fingers are in now on either side of the spine, so I'm resting in the lamina. I'm using my arms to create a fulcrum so I'm able to lift my fingers towards the ceiling. So the finger pads are in the lamina, and I lift up, and I'm going to hold that position until I get a sense that there's an increase in the pliancy in the tissue, or a softening, but also a feeling that the vertebra at this segment starts to move a bit more anteriorly. And one of the ways that you'll be able to confirm that this is proceeding well is, of course, as we often notice, is that there'll be a really nice increase in the sensation of the client's weight. They let their weight rest into your fingers, and as that happens, you'll notice that suddenly the bone doesn't feel as fixed in its position, and just the kind of direction of your fingers will help that bone move from posterior to anterior slightly. And it's not a big shift. It's not anything resembling a manipulation, for example. And I would just work that systematically through that segment. So I'd just then go to the next vertebra and hold it in that same direction. So that's just being lifted towards the ceiling. And once you start doing this 20, 30, 40 times, you'll discover that your fingers are quite quickly able to isolate the level at which the most restriction's taking place, and that's where you're going to focus. But to begin with, just work this mechanically, and by mechanically I just mean systematically. I'm going to do the same thing in the cervical spine, and you'll be able to see this a little more. I'm going to have my fingers in behind either side of the spinous process. I'm going to lift towards the ceiling. Take up attention towards myself in the tissue slightly, and then also spread from medial to lateral. So I'd just like to do the uptake of that position again, so you can see how much Marin's neck is affected by that it's quite literally lifting her spine. And I'm thinking right through to the multifidus, the small muscles, the deep small muscles. And once again, working systematically at the outset, and the more you do it, the more you'll be able to ascertain where it is that the specific restrictions are, and that would then be your focus, of course. And this is slow and it feels great. Landing, sinking, which means lifting in this instance, putting a little bit of tension in the tissue towards myself, and then a slight lateral spread. So I've just moved up. I'm at the C2, C3 area. And so on. Using the skeleton this time to show the placement of my fingers for lifting the vertebra. And so I'll just roll the skeleton slightly on the side and show how my fingers are lifting in really into the laminar groove, and that puts my fingers in behind the articular pillars, and I'm lifting then towards the ceiling. So I'm taking this in the anterior direction, lifting up, making a fulcrum, waiting for a response through the tissue and the ligaments, feeling a softening, things give way, the vertebra will feel that it has more spring to it, more glide, and I'll just work my way up vertebra by vertebra in that manner, creating those fulcrums. Doing this slowly, so it's different than, say, joint mobilization. So I'm not really working at it very quickly, but a nice sustained contact gives the body plenty of time to find the pressure and release and relax over onto it. At the Atlanta-occipital junction, we've got a few really useful things that we can do, and the value of that could hardly be overstated. We've got this somatic, sympathetic, parasympathetic outflow from this area. We've got rectus capitis posterior minor, which runs from the occiput to the atlas. A highly important muscle. It's been shown to have an effect on tethering the dura mater within the spine at that segment, so contributing to the stability of the dura mater in relationship to the surrounding vertebra, as well as rectus capitis posterior minor and rectus capitis posterior major having this huge number of muscle spindles, in fact more muscle spindles per fiber than any other muscle in the body or any other muscles in the body. So huge effect on proprioceptive inputs, determining of tone through that whole
extensor chain from starting at the occiput and going right down through the back of the body. So very influential in the well-being of the body, this region, the whole body. The first position is just to make a stand with my fingers, which is what I'm doing here. I'm showing you away from Marin's head, and her area of her occiput is going to rest against the pads of my fingers in a moment, and the tips of my fingers will be intruding right up into towards the posterior arch of the atlas. So if she lifts her head up, that's the easiest way to do the uptake to begin with, and she rests back down, and there I've made that fulcrum. And so she's resting onto it, and I'm just resting there and providing a stable fulcrum and letting her head drape over it. It takes some time to condition your fingers for this, and that's very common, and don't be concerned if you find your fingers fatiguing when you first start doing this, and I'll show you a way to work with this that respects that and doesn't challenge your fingers any more than necessary. So my fingers have been doing this a fair while, and so I'm happily holding Marin's head up on my extended fingers here and waiting for palpable softening, at which time several things will feel to happen at once. One is that the neck will elongate, and so it feels like the whole cervical section will sometimes grow a couple of centimeters in length. The other thing is that I'll notice also is that once again there'll be this enormous increase in the weight of the head, and this is also a good sign that we're getting a really significant change in the tonus through this whole region. So the next thing that I'll be doing, and I'll show with my fingers, again, before I put I'm going to work much more specifically now with these middle fingers right at the midline, and I'm going to take my fingers right up towards rectus capitis posterior minor, and then I'll put a very slow lateral spread by just supinating my forearm slightly. So first of all, landing and sinking the way that we do, and then working apart. And I can do that by just pulling my elbows together and supinating my forearm slightly. So once again, I'll ask my client, Marin, to lift her head up. I'll just pop my fingers under there. And this is how we'd also do the first one. If your fingers are fatiguing with that, making that active fulcrum, then just rest them right back down onto the thenar eminences of your hand, and let the weight of the head be shared between your fingers and those pads here, and even that amount of contact and that amount of pressure will be helpful to release this whole occipital base area. So here my fingers are very local at the midline, pointing towards the ceiling. Starting to take my fingers apart, and that's just a slight supinating action. So I'm in effect providing a drag in the tissue, or taking up a tension from medial to lateral. It's not terribly high force, and because it's not high force, there's much more chance that the client will just allow themselves to be taken along for the ride here. And the other thing is that you're able also to feel that there's an opportunity then to really feel one side might be tighter than the other, and so you can give a little bit more focus to that which is tight. And the way to do that is just to roll the head towards the tight side and take up a little bit more tension there. And that's what I'm doing here. I'm just rolling Marin to the left, and that enables me to get a little bit hooked in to the left with a bit more of a line of tension there. Then the next thing I'm going to do, once I've cleared that level of restriction, I'm going to take those middle fingers back into the suboccipital area there. So I'm really making a space between C2 and the occiput, walking my fingertips into that, and then actually hooking onto the occiput and pulling down towards the table slightly. So this time I'm not so much spreading laterally,
but I'm actually translating the head as much as I can. It's not very far, you can see. If I push into the table, it's maybe a couple of millimeters, but I'm taking the head now posterior and then walking my fingers into the gap that I've made, and there's the posterior arch of the atlas. And that's where rectus capitis posterior minor is. So now I've got my fingers right up against the periosteum of the bone that rectus capitis posterior minor belongs to. And there's a little bit more translation. You can see as Maren releases there, there's quite a appreciable change in position. There's good, and now I've got a really good sense of being able to go right up against the posterior arch with my fingertips whilst I'm still providing that tractioning or translation force towards the ground. And then slightly towards myself, so I've added another direction, which is now a light superior traction. It's not very strong. I don't want to create a guarding or a pulling back. And then I'll just roll the head to the left. And roll the head to the right. Almost just kind of walking the head off the neck slightly or rolling it off. So my fingers and my hands, so I'm kind of working in some kind of concert here between this rolling motion and my fingers underneath, just making more space there right at the base of the skull. So as we take the pressure off, anything that we do to take the pressure off the occiput and the tension from all of the muscles on the occiput impede the outflow and the inflow, but particularly the outflow of fluid from the cranium. So we've got, and also some of the, particularly the vagus nerve, which comes through the jugular foramina. So it's following the venous return system out of the cranial base, and if all of this area is under a lot of tension, then often the outflow of the fluids impeded, and so too is the outflow of the vagus nerve. And that's the major parasympathetic nerve, and we'd certainly, in most people, we would like to encourage that parasympathetic activity to resume. Because often it's been really impeded by compression at the head, trauma to the neck, overly excited sympathetic system, stress accumulation, life history stuff. Okay, so that's how that looks. The work done at the base of the occiput into that suboccipital area is reinforced, I think, by seeing it again with the skeleton. I just want to draw attention to the pads of my fingers, which are up against the occiput itself, and then the tips of my fingers are what then go in towards the atlas. But it's worth bearing in mind that at the outset the soft tissue needs releasing, because the occiput and the atlas are much more sitting in this way. The space that we're able to work into is between the occiput and the axis C2, and it takes quite a bit of time to start to create some space so that we can get our fingers onto the deeper posterior arch of the atlas there. So the first thing is the finger pads are on the occiput, the fingertips are intruding into that space, and that's where we have the fulcrum, building the fulcrum there, and then also spreading. The hands. Then the way we start to approach the atlas itself is with the two fingers at the midline, using the fingers in this instance then to traction or translate the occiput towards the table. So I'm going to just show what that looks like. So I'm taking it this way, pulling down, and I walk my fingers up into that space, and eventually I start to feel that I can get my finger right through onto the atlas. So we never get as much space as I'm able to show here, but I just want to illustrate the transition that gets made from the occiput being fairly hard down towards the axis, and progressively as we move our fingers up into there, we'll be able to get our fingers onto that posterior arch of the atlas, and that's where rectus capitis posterior minor is attaching, and we're able to work, do a little bit of sifting, sorting, if you like, through the tissue right over the posterior arch itself. So that's where we're heading, and we start with the broader work, fulcrum, softening, spreading the tissue there, and then we can start our walk in with the fingers. Using a young pediatric model here to show some variations on position, and positions that I found useful to have in our sort of bag of tricks or our repertoire, again because of the need to be pretty versatile about how we're going to engage with the child. That's not always going to be lying still or doing the kinds of things that we might like ideally for them to be doing. And so this side-lying position can be very helpful, one to work in. Sort of like the supine position, because of the high flexor tone, very hard for them to lie on their back, and so finding ways to work in the side-lying position can be extremely useful. Here I'm working into that area just posterior of the transverse processes, so there I'm palpating the TPs for you. You can see those, or at least see where my finger is in relation to those. And then I'm able to just take my finger into the back of those TPs and work from inferior to superior. And I would work along that line there. And it would be slow, if possible, and melting. So a lot of very sort of systematic work. Just thinking about each segment in the spine, thinking about affecting that deep layer of musculature there. So taking that through really into the multifidus ultimately, even though we might start with effect on some of the fibers of the trapezius. It's also a good position to affect some of the fibers of the levator scapula through here. So think about the root of the spine of the scapula and how we're able to bring our fingers along some of those fibers as well. So that whole territory can be very nicely affected through there. Same with the neck work that I was doing in the supine position. I can bring a broad soft fist onto the side of the mastoid process there. And you can see here that I don't even have to confine this to the mastoid. I can also let the rest of my fingers get the superficial fascia, and I can bring all of this tissue from anterior to posterior. So that's affecting, again, that same area of that convergence of different myofascial structures that go to the mastoid process of the temporal bone and to the occiput. The work around the suboccipital triangle is very similar to the work that I did in the adult model. One thing that we need to keep in mind is that the pediatric client might not be as inclined to just rest into our fingers here. And so that aspect of the contact where we're able to just lightly hook into the occiput and then bring it down towards the table can help increase the amount of release that we're able to generate here. So that's what I'm doing here with my young model, is I'm taking my fingers up into that suboccipital area, but then I'm also using my finger pads to kind of pull down on the occiput at the same time, slightly towards the table. And sometimes I find that if we can just persevere with that, without being overly aggressive with it, of course, that many times we'll start to get the kind of deep myofascial release that then leads to the whole organism going into a deeper state of relaxation. And that's what's happened here a little bit. You can see that there's been a certain degree of kind of fiddling around and agitation, but now after 30 seconds or so, a minute have passed, there's been a bit of a kind of slowing down of all of that, and that's relatively common. Although I think this young man is still interested in building up a six-pack, is what he stated as one of his ambitions, so he seems to be doing some sort of abdominal exercising. But you can see that the overall sort of fidgeting factor has reduced almost to nothing, and that's pretty common. If you can just sort of hang out here and keep the head down in your fingers, then you'll, not always, but you'll quite often then, and then we start to see the overall sort of slowing in the breathing, a nice relaxation response in the neck. And this is a nice starting place for some children who find it difficult to calm themselves and basically inhibit the overactive nervous system. That this helps with that process, and that once they've established this initial level of relaxation, then quite often, there you go, then you'll start to notice that it goes in more deeply, and they start to get a sense of to how they can do some of that themselves. And this is a nice discovery for a lot of children. Yeah. So this is what we've got here. You see the yawning sort of slowing down, and yeah, generally the whole body starting to go into a more kind of rested state. And so for any kind of, this can be a nice preliminary for other kinds of therapy that require the child to be able to do some self-dampening of the overactive nervous system. And so this gives them some access to those processes, which many of us, of course, take for granted because our nervous systems don't have those kinds of deficits. And this, of course, is also a lovely prelude, or a nice way this can transition very easily then across into more specific kinds of cranial work. But at this point, I would consider this to be a kind of transition process, that I'm not really thinking so much about cranial rhythmic impulse or primary respiratory mechanism, but I am sort of sensitive to those effects across not only from the musculoskeletal system and the myofascial system, but more into the fluid and energetic processes. And and this has just been a good example, I think, of that progressive sort of slowing down of the nervous system that can take place.